Okay. So good morning, everyone. Welcome to today's event. We're so happy that each and every one of you are available to be part of this event today. My name is Omotoyosi Ajishomo. I'm a project coordinator with EARTH Africa, and we'll be focused on renewable energy in Africa, its impact on public health and sustainable development. We're going to be very strict with time because different people and stakeholders have different things happening today. So without wasting anyone's time again, we would like to move to the first event of the day by Juliet, who will be giving us the welcome address. Over to you, Help Desk.
Good day, everyone. My name is Juliet Odogu, and on behalf of eHealth Africa, I would like to welcome you to this roundtable discussion. Today, we're here to discuss renewable energy in Africa and its impact on the public health landscape and sustainable development at large. In Nigeria, sustainable energy is one of the major challenges affecting the public health sector. Most health facilities run on unreliable power sources, and this can interrupt healthcare delivery. It can disrupt the needed cold chain for vaccines and interrupt life-saving equipment. When reliable power is unavailable, all other aspects of the healthcare system's strengthening becomes really hard to achieve. At eHealth Africa, our goal is to build stronger health systems, and one of the primary ways that we do this is by providing data that can inform and improve decision-making in the public health sector. We've built our expertise on data management, from data collection all the way to data visualization and analytics, and we have over a decade of experience in providing crucial data to decision makers in health systems across Africa. Over the years, we've also worked with national and state primary healthcare agencies in Nigeria to provide cold chain officers and immunization officers with the necessary data around energy consumption to aid things like cold chain equipment utilization and placement. We've also partnered with a number of energy researchers and service providers to gather the necessary data that can be used to model energy planning and consumption in Nigeria. In addition to the data that we generate, we also work on setting up and maintaining physical infrastructure that's crucial and very critical to public healthcare planning, implementation, and delivery. Since 2012, we have built and equipped 8 polio emergency operation centers in Nigeria and many more across West Africa as part of our goal to strengthen our partner government's capacities to respond to public health emergencies. Through these projects, we've realized the immense need to deploy renewable energy solutions within these structures to support 24/7 program planning and coordination, as well as efficient emergency response. Our diverse project experience, as well as engagement with other partners within this space, has further highlighted the need for collaborative forums such as this, where stakeholders and thought leaders in the energy and public health landscape can discuss the challenges around power and energy in the health sector, showcase the opportunities available for increased use of renewable energy in strengthening health systems, and share lessons learned and solutions through various interactive sessions. I want to say a big thank you to our partners, EHA Clinics, Haven Hill Synergies Limited, Integration Environment and Energy, the Renard Lemoine Institute, the Electricity Hub, and the Rural Electrification Agency for agreeing to be a part of these discussions. Also, I would like to thank the Kano State Government as well as the Kano State Primary Healthcare Management Board for their support, for their continued support throughout the years. I look forward to the rich conversations that we're going to have today. Thank you all very much for your participation.
Thank you very much, Juliet, for the introduction, background to EHA's work on renewable energy and public health. And thank you everyone for joining us once again. My name is Omotoyosi Ajishomo. I'm a project coordinator with EARTH Africa. Again, thank you for joining today's webinar focused on the theme, renewable energy in Africa, its impact on public health and sustainable development. By the end of this event, we would have highlighted the challenges around energy in the health sector, discussed the opportunities available for renewable energy to strengthen the Nigerian health system, and finally, we would have a diverse group of subject matter experts share their lessons that they've learned over the years, as well as solutions related to renewable energy and public health. Please be rest assured that this event is packed with key actors, experts from these sectors, and we'll be having thought-provoking conversations. As we go further in this event, we would like everyone to know that as a participant, you have restricted rights access, so you can only see write in the chat box and listen to presenters. The agenda is on full display, as you can see, and we would like for everyone to keep to the time. Also, at the top right corner of your screen, you can use the Q&A box to drop your questions. Kindly address it to a specific speaker, and then you would also have the opportunities for the speakers to answer your questions. Once again, welcome, and then we can move on to the next agenda, which is a presentation by Unavoidable, who is a coordinator of renewable energy operations engineering with EHEalth Africa, as well as Tahir Buhari, who is also a project manager with EHEalth Africa. So we can now go ahead with the presentation.
Thanks, Omotoyosi, for the introduction. As Omotoyosi has said, my name is Tahir Buhari, and I'm a project manager working with EHealth Africa. And my co-presenter today would be Onche. We will be talking to you a little bit about power quality access challenges in low resource settings as part of a research study that we conducted with one of our donors, the New Horizons of Global Health Labs, in 2019. So with that being said, let's go ahead and go into the slides. Okay, next slide. So for the presentation today, we will first of all talk a little bit about an overview and the background information in terms of access to power, and then why improved access to power is equals to better healthcare, and how a new generation vaccine refrigerator called the Metafridge is illuminating power availability and quality, especially in healthcare facilities in Nigeria. And then it will be important for us to establish and define some key power terms just to help you understand some of the findings from one of the research studies that we conducted, and then go into conclusions and our recommendations for how we see things moving forward. So it'll be really difficult for us to have a conversation about access to power without really looking at SDG number 7. And SDG 7 aims to ensure access to affordable, reliable, sustainable, and modern energy for the entire world's population. Now, if you look at this particular SDG over the past decade, there has been some significant progress that has really been made. And now, yes, this progress has been made with 1 billion people gaining access, more than 1 billion people actually gaining access to electricity. Okay, so it will be really difficult for us to have a conversation about power access without looking at SDG number 7. And SDG number 7 ensures, no. Okay, another take. So it will be really difficult for us to have a conversation about access to power without really looking at SDG number 7. And SDG 7 aims to ensure access to affordable, reliable, sustainable, and modern energy for the entire world's population. So if you're looking at this particular SDG number 7, there has been some significant progress that has been made over the past decade, with more than 1 billion people gaining access to electricity since 2010. So while the number of people without electricity has declined from 1.2 billion people in 2010 to some 759 million people in 2019, by that same year of 2019, more than 90% of the world's population has actually been connected to the grid. However, this progress is skewed. So if you look at this number, the number of people without electricity actually increased in sub-Saharan Africa. And unless efforts are significantly scaled up, especially in countries with the largest deficits, the world will still fall short of ensuring universal access to electricity by 2030. So it's important for us to really critically look at SDG 7 and see where this unequal access is. While more than 1 billion people gained access to electricity globally over the last decade, COVID's financial impact, for example, has made basic electricity services unaffordable for an estimated 30 million people. and the majority of these people are located in Africa. Nigeria, the DRC, and Ethiopia had the biggest electricity deficit if you're looking at this data over the past decade, with Ethiopia actually replacing India in the top 3 countries as tracked by SDG 7. So over time, especially for primary healthcare facilities in low and middle income countries, they have been characterized by infrastructural decay, a loss of health inventory, unavailability of medical equipment, poor staffing and working conditions. In a lot of our primary healthcare facilities, vaccines are either sometimes unavailable or cannot be properly stocked or stored. There's a lack of potable and clean water, which is another major challenge. Medical staffs are also forced to source for water from local vendors without knowing the source or quality of such water. And where boreholes exist, many are either broken down or are not powered. So in addition to all of these challenges, several primary healthcare facilities are unable to render services beyond 5 p.m. due to this lack of power to provide illumination at night. So medical personnel are therefore, forced to rely on rechargeable lamps, kerosene lanterns, or petrol-powered generators to provide nighttime emergencies. So this is the situation as we see, access to power when it comes to healthcare facilities in Nigeria. So, but it is also important for us to really look at why is improved access to power equal to better healthcare delivery for systems. I want us to talk about a specific study that was conducted in 2018 by the WHO and the UN Women Foundation, and that study specifically looked at how to improve energy access and energy resilience of health facilities in low and middle income countries with the aim of stimulating more optimized use of modern energy technologies and renewable power sources. According to that report, the quality of energy access in health facilities may have cross-cutting impacts on other aspects of health services. These may include, for example, the hours of operation. So for health facilities that don't have power, they may be forced to close at 5 p.m. Retention of health workers who live close to the health facility, and a host of other issues. Another one is inefficient use of energy technologies, for example, powering small medical devices with oversized generators. This sometimes contributes significantly to high fuel waste and high cost of provision of power to health facilities. So it is really important for us to have improved design of power systems, which includes careful sizing of power systems, timing and appropriate integration of renewable energy sources so these can reduce the costs of providing power to health facilities. There was also another study that looked at 11 major sub-Saharan African countries, and that study found that roughly 1 in 4 health facilities had no access to electricity, and only about 1/3 of hospitals had access to reliable electricity. So even the lowest health facility at the level of maybe like a health post or a dispensary requires connection to power in order for it to function properly. So these decentralized renewable energy solutions coupled with efficiency measures have great potential to really expand health facility access to cost-effective and reliable energy, especially for low and middle income countries. So before we go into the next section, we wanted to talk about a specific study that we conducted with our donor, New Horizons of Global Health Labs. We conducted this study in 2019, where we looked at data from health facilities in Nigeria and collected voltage measurements and other priority power data to really look at, what is the quality and availability of power in these kind of settings. These analyses proved to be very, very valuable, especially for specifications and standard setting bodies and, equipment designers, purchasers, users, and generally the larger EPI program. So I'm going to hand over, first of all, before we go into the findings of the study, to Onche so that he can talk about, power quality, some of the power quality issues, and some of the effects that we see as a result of poor power availability and quality. Onche.
All right. Thank you, Tahi, for that brief The primary purpose of our energy system is to contribute to a better quality life, and to those institutions that have power or energy, it unlocks improved healthcare, it leads to improved education, improved economic opportunities, and even longer lifespan. To those that don't have, it's a major constraint on their social and economic development. In sub-Saharan Africa, made up of about 48 member states, they are constantly prone to lack of energy, and the electricity generation capacity of the region, which with a population of about 1.3 million, is about 68 gigawatts, which is being comparable to that of Spain with a population of about 45 million. According to International Energy Agency (IEA), in 2040, it's made that energy demand in sub-Saharan Africa will continue to grow by about 45% from 2000 to 2012, which accounts to about 4% of global demand, despite being home to about 13% of the global population. The outbreak of COVID-19 has exposed sub-Saharan Africa to issue of lack of proper energy in sub-Saharan Africa. It has stretched the healthcare sector, thereby causing international organizations like WHO and other undeveloped countries in terms of providing vaccine for the sub-Saharan Africa. And the reason why there is a decrease in the supply of vaccine to Africa is because they said Africa doesn't have reliable power system, thereby supplying vaccines which they have invested millions and billions of dollars will result to wastage, because this vaccine operates at a particular certain temperature. Any variation of this temperature will reduce the potency of this vaccine. And which leads us to why do we have all this issue? Power quality is, the quality of power supply is very important in any power network, particularly to electricity consumers. Power quality encompasses availability of supply, frequency and voltage magnitude, as well as waveform characteristics of the power supply. And power quality can be explained to be the degree to which the supply power is compatible with the smooth operation of all electrical equipment. Power quality can be defined as poor when the supply is not constant, when at least one of the when the supply is not constant, when the supply voltage is lower compared to what these devices can take. Power quality can also be defined as the power system frequency being fluctuating, which we have experienced in some of our homes. Can also be defined as the current and voltage being, the current and voltage is supposed to be sinusoidal waveform, but there's distortion in the supply. So power quality is very, very key to some of all the operation of our devices. So we're going to look at, because of this issue of power quality, what are the causes why we are having all these power quality issues in Nigeria, specifically to our distribution network. One of it is as a result of lack of maintenance and network refurbishment of aging infrastructure. We have seen across several places in Nigeria, we have low maintenance culture. Degrading of this infrastructure leads to, has really affected the supply of good power to some of all these devices. Aging, lack of maintenance, and refurbish of aging infrastructure. True. Secondly, is the growing customer base without commensurate increase in generation capacity. We all know when we're small, we have about 500 kVA transformer in a particular community, and there's the probability of this community being increased in terms of population is about 100%. As the population keep on increasing, the transformer which is being mounted to supply power to this locality remains the same, and this overstretched the operation of the transformer over time. What will happen is that the transformer will continue to get burnt, they will recoil, get burnt, they will recoil and get burnt, because we don't have proper database to account for these customers so that they can be able to increase the generating capacity. 3, illegal connection, which result in increasing the unmetered demand to unknown level beyond network design. We all know that every household needs power, but due to the economic situations, customers find it very difficult to pay their utility bills. Thereby, at night, they call a particular local technician to come and hook them up. And because when they hook them up, the discos, the distribution companies, can no longer recoup the money needed to be able to buy this energy and sell to the customer. So which leads to failure in the supply line. We also have what we call the vandalization of public utility. We all know during riots, people, the rioters target government facilities, target power lines, get them burnt down. We have experienced that burn down of power supply, especially during during the Boko Haram. They go to power line, destroy power line. This has also affected the power quality of power quality supply to the customers. So let's look at what are the effects. Yes, we have looked at the cause. Let's look at the effect. What is the effect of power quality? It leads to loss of production. Each time production is being interrupted, we lose businesses, lose the margin of the product that is being manufactured. In any manufacturing industry, if there is a shutdown of power, if there is a low supply of power to that machine, what happens? Production stop. But the client have already been given a timeline that this product will be delivered to this particular period of time. But when we have a shutdown in the terms of power quality supply to those machineries, what happens? It leads to loss of production. And when there's a loss of production, the business will lose its revenue. Two, it leads to damaged product. Interruption can damage a partial or complete product, cause the items to be rerun or scrapped. Yes, we have experienced that in our clinic when they are running the COVID-19 test. The samples are bought, the reagents which is being used to run the COVID samples are gotten from outside the country. When these samples start running on Attila, any short of power supply, that reagent, that sample is bad already. God is no more useful. Thereby, they have to throw away those samples, get a new reagent, call the patient the patient back for resampling, collect the sample and rerun it again. That is one of the problems which with the effect of power quality. And we also have hidden cost. If the impact of such is controlled error, a product, it can be a defective. If there's a hidden cost, when there's power shutdown in a particular product that is being run, it leads to defective product defective product which will eventually be the outcome of the product being run. We can take, for instance, for those people that are in the ceramic industry, we have Class A, Class B, and Class C product that's being run. One is the product which is being run continuously without power interruption. Class B product is being run, but there's a failure in the supply of power. It stops production, and when the power comes, that is Class B. The same thing happened to Class C. So this is how they grade some of all those products, and which will lead to reduction in revenue because they can't sell that particular ceramic, that tiles, like the one they sell at grade A, which was not affected by power. And we also have huge loss of medical equipment. Medical equipment, telecom equipment are very, very sensitive to power fluctuation. And anytime there's a power fluctuation anywhere, the medical equipment eventually get bad, and these are equipment that are very, very expensive. Let's take, for instance, there's an issue that happened in one of our offices where we have the high-fame freezer which stores some of the vaccines. We have a spike in the voltage supply, and it damages the control board of the ultra-cold freezer. What happened? That whole control unit was we lost it due to the spike of voltage. And what happened? It takes a longer time before the replacement can be made. The replacement was made. And what happened? The vaccine that was stored in this freezer, in order not to lose the potency of this vaccine, what happened? We have to contact the IFN representative to come and remove the vaccine and take it to NRL for proper storage. So these are some of the issues, some of the effects of power quality that we experience in our country, Nigeria. So I'll hand over to Tahi to continue from here, then we move forward.
Great, thanks, Wanche. So before we go into some of the key findings from the research study that I was mentioning earlier that we conducted in collaboration with the New Horizons of Global Health Labs, it is important that we define some of the terms that are contained in that particular research study. So the definition of the terms can vary across the electrical power industry. So these definitions are specific for the purpose of this presentation and the research study that was conducted in 2019. Some of these terms can be visualized on the figure 3, which shows voltage ranges and an example graph of voltages over time. The example traverses all of the voltage ranges that were contained in the research study. So the first one is nominal voltage and frequency. And this is the expected value of voltage and frequency at the electrical outlet, meaning the power that you get out of your normal socket. The nominal grid voltage in Nigeria is 230 volts, while power system frequency is 50 hertz, with a desired rate usually between 48 and 51 hertz. Then we have usable voltage or normal voltage. This is the green area on the figure 3 there. So this is when the voltage at the outlet is within plus or minus 10% of the nominal voltage, which in Nigeria is 207 to 253 volts. Equipment is often designed to operate over a similar range. We also say that power is usable when the voltage is in this range, meaning that equipment can draw power from the outlet. And then we also have usable power with stabilization. This is when the voltage is between 110 and 278 volts. This is the range defined by the WHOPQS voltage stabilizer specification. This includes the usable range above and below. The areas within this range but are outside usable range are said to be stabilizable and usable if you use a stabilizer. So that is the amber area on figure 3. Then we also have unusable voltage. So this is voltage outside the stabilizable range, either above it or below it. This includes interruptions or service interruptions, which is a period when voltage is completely unusable. This is usually defined by when the voltage is less than 10% of the nominal voltage. So that is 23 volts for Nigeria. We also have overvoltages. Overvoltages is a period when the mains voltage increases more than to 110% of its nominal value. And in Nigeria, that's anything more than 253 volts. Then we also have undervoltages, which is the period when the mains voltage decreases to less than 90% or less than that 110 value for Nigeria. And we also have periods of data outage. This is a period when data on power quality were not received for more than 30 continuous minutes. Example of these conditions that could cause data outages are extended interruptions that can exceed the monitoring equipment's battery charge and equipment failure. So going into the details of the study, we conducted the study in collaboration with New Horizons of Global Health Labs, as I mentioned, and we deployed 93 metafridges in some 8 states in Nigeria, including the Federal Capital Territory. Some of the states where we had fridges installed were Kano, Jigawa, Oshun, Abia, Enugu State, Nasarawa, Plateau, and Gombe states. And data collection from those devices started as installations of the devices began in March of 2018, and that data collection continued up until August of 2019. This data was collected by the Metafridges Integrated Remote Performance Monitoring System. That is one of the key features of this new generation vaccine refrigerator. It not only monitors, your storage chamber temperatures, your ambient temperatures, but it also actually monitors the power that is incoming from the health facility, and it also monitors the quality of that power. We can tell whether the power is from the grid, whether the power is from the generator. So this new generation vaccine refrigerator is really powerful, and it's providing us with so much information in terms of the environment these healthcare facilities are. All of the devices that were included in this study reported power data for at least 1.5 continuous months, with an average of 10 months of data being reported per device. So I decided to, pick some key findings from the research study, and one of the ones that I think is very, very relevant for us is looking into the availability of usable voltage. Electrical equipment are generally designed to operate over a relatively small range of voltages, which is often, plus or minus 10% of an ideal nominal value. And these voltage fluctuations beyond that amount can reduce the performance or sometimes even completely damage that equipment. So voltage stabilizers can be used to extend the usable range. And on figure 7, which shows an overview of all of the voltage samples gathered over all the devices during the study, we understood that we split those into 3 categories or 3 groups. The first group was usable with a stabilizer. So this is power that was usable without a stabilizer, this normal power. Then we also have usable power if stabilized, and then we also have unusable power. And in Nigeria, for all of the devices that we monitored, usable voltage was available 27% of the time without the requirement for stabilization. And if we used stabilization, this power would have been usable for an additional 15% of the time, which suggests that voltage stabilizers could be broadly useful in some of the health facilities where these equipment were deployed. The remaining 58% of the time, the voltage was unusable during the study period. One possible evidence-based policy that can be made with this kind of information and this kind of data would be to focus the distribution of voltage stabilizers to facilities that could benefit the most from stabilization. So you look at for which fraction of time usable power would be most strongly increased, and then you look into how that distribution of stabilizers can be more targeted towards those facilities with usable power with stabilization. The second finding that I wanted us to also look at was interruptions that we monitored over the same period. So interruptions can occur between the electricity source and the device for many reasons, as Onche has gone over a number of them. The electrical utility may experience some sudden or long-term generation capacity shortfalls. This can be either system-wide or this can be local. And as a result, the utility may shed load on parts of its system to balance the energy supply and demand. And then also at the facility level, circuits may be overloaded, leading to maybe tripped circuit breakers and or damaged wiring. We could also have a situation where facility staff may unplug the device to move it within the facility or even to another facility. So one caveat to keep in place here is within the research study, we may not necessarily be able to tell exactly why these interruptions were happening. We were only able to monitor the data for that same period given the remote performance monitoring system data monitoring capabilities. So for the purpose of the study, an interruption is defined as a period with unusable voltage that is outside of the PQS specification, which is 110 volts to 278 volts input range. So for the study, across all of the 93 devices in Nigeria, during the full 18-month period of the study, there were 1,145 reported interruptions longer than 48 hours. And there were 36,549 interruptions that were longer than 30 minutes. This averages to about 15 interruptions per year, longer than 48 hours, and about 453 interruptions per year, longer than 30 minutes for each of these devices. If you look at the graphs on the left side of this deck, on figure 13, it shows how interruptions of 48 hours or longer are distributed between the devices. 8% of the devices had no interruptions longer than 48 hours, and 32% of the devices had more than 0 or less than 6 interruptions per year on average. The remaining 60% of devices average between 6 and 73 interruptions longer than 48 hours per year. And then if you look at the right side of figure 13, which shows the breakdown of devices in Nigeria with interruptions longer than 30 minutes, all devices reported some interruptions of this length, and 38% of devices reported an average of some 480 or more of such interruptions per year. So why are interruptions really important and why do they matter? Mains-powered vaccine refrigerators are an example of broadly deployed equipment that must continuously maintain performance through interruptions. the ability to maintain that temperature between 2 to 8 degrees, and Onche did make some references to this, is really important, and this is something that is commonly referred to as holdover time. The WHO PQS standard for holdover time is for intermittent mains powered cold chain equipment is broken into 3 major categories, where there is a short holdover devices, which is holdover between 20 to 48 hours, medium holdover devices, which is about 48 to 120 hours, and then we have long holdover devices, which last for about 120 hours or more. So if you're looking at this study, again, 92% of the devices in Nigeria during the study reported some form of interruptions that is longer than 48 hours, which indicates that a short holdover device, a device that can last between 20 to 48 hours, would not be guaranteed to maintain safe storage chamber temperatures in a substantial portion of these facilities. So it is quite important for Nigeria, for example, to look at long holdover time devices to provide additional vaccine safety here, where the percentage of facilities where devices reported interruptions longer than 120 hours, that drops to 65% when you're looking at the study in Nigeria. This is also indicating that increasing the holdover time from 48 to 120 hours would provide additional vaccine security for an estimated 27% of the measured facilities over the period of that study. So based on the specifics of this particular research study that we conducted over nearly an 18-month period, monitoring the availability and quality of this power and electricity as measured by the metafridges, which are operating in some 93 health facilities, we can conclude some of the following based on that data. So in Nigeria, 76 out of the 93 devices reported usable voltage less than 50% of the time. This is providing WHO pre-qualified PQS range voltage stabilizers, reduces the number to 66 devices, which is about 71%. So with usable voltage less than 50% of the time. Moreover, it shifts many of these devices with 0% to 20% availability, which is closer to 50% if you take into account some stabilization. This indicates that voltage stabilization would benefit individual health facilities where high power availability levels, reliable operation, and long lifespans are required for medical equipment. Also, while most reported service interruptions during the study period were short, Nigeria, the health facilities in Nigeria reported a significant rate of multi-day interruptions at the health facility level, with 92% of health facilities in Nigeria experiencing interruptions in excess of 48 continuous hours, and at some point during the study. So these data indicate that devices requiring continuous operation, vaccine refrigerators, for example, and freezers, should be designed for multi-day interruptions, even when intended for locations that are expected to have relatively reliable electricity and grid services. And also, during the period of the study, the devices that reported voltage conditions can potentially permanently damage improperly protected equipment. So sustained under and over voltages can significantly damage medical equipment and equipment through overheating of motors or other electronics. So if we take into account some of these recommendations, this will really help to gear our procurement policies and our plans when it comes to improving healthcare when it comes to the health facilities in this part of the world. So before we go, I'm also handing over to Onche to talk about some of the approaches that we have used, given some of the things that we've learned from this research study about EHA's approach to managing some of this renewable energy.
Thank you, Tahi. Thank you, Tahi, for your presentation. We'll continue with EHA approach to power quality issues. EHA has done a lot of improvement in terms of improving power quality in some of their business area. The first pictures you have seen there is one of EHA residents where when they undergo power lack of where they experience poor power quality in our residence in Abuja. The picture you see there was a huge spike of voltage from the grid supply, which affected a couple of appliances inside the residence, and they experienced some appliances, they lost a couple of appliances. So EHA decided the electrical team the engineering team has to embark on investigation to know the cause of the issue, which is due to spike of voltage from the transformer, which is 1 MVA transformer, and also aging decay of the feeder pillar. What we noticed there was decay, insulation breakdown in the feeder pillar. So what we did was that we had to replace the feeder pillar, the transformer unit, and also that's both from the transformer and also from the feeder pillar also. And also the picture you're seeing there is an automatic voltage regulator, which we installed there to ensure that if there's a spike of voltage, the servo drive system, which is the AVR, will be able to regulate the amount of voltage supply to the building. So if there is a high voltage, the automatic voltage regulator will bring it down to a usable limit, and if there's an under voltage, it boosts it up to a usable limit and feed clean power quality to the building. That is what we EHA have done in the rest end. The second picture you're seeing there is the AVR, 500 kVA AVR installed in NCDC NRL. We know that this is one of the biggest laboratory in Nigeria, housing over 100 ultra-cool freezer. And if without this AVR, they are having power quality issues in NRL. So EHA decided to install automatic voltage regulator servo drives to cater for any power issue that may occur, and which will, if it occurs, is going to affect the freezer and the potency of the area of the vaccine stored in the freezer. So we installed the automatic 500 kVA AVR in NCDC NRL, and also we did 250 kVA in their headquarters in Jabi in Abuja there. So that is what EHA have done for our partners. The next picture you're seeing there, the first picture you're seeing there, EHA decided to embark on decentralization of the power system across all our EOC. We have about 8 EOC. 6 of these EOC are completely off grid. They are not grid connected because of the quality of power supplied from the grid, which has affected a couple of our EOC. We have the Kaduna EOC, which was affected by surge and destroyed a couple of appliances there. And we have a couple of incidents that has happened across all our facilities. So we decided to go on a decentralized power system. So we decided to conduct an energy audit. So we installed 21 kilowatt inverter system completely off grid. And this EOC are focal point for the COVID vaccine mobilization. So all the primary healthcare workers, they come to the EOC. They have uninterrupted power supply and internet services across all the EOC. So we have 6 EOCs that are completely off grid. They are not grid connected. And also we have 2 other EOCs that are a bit grid connected. In Kano, we have the cold chain store, which EHA is supporting, and also in Abuja because of the capacity. So we have 6 EOC completely off grid, and the other EOC, they are partially off grid. So we have the middle picture there, that is me on check doing quality inspection check on the solar panel. So EHA is expanding its business model in terms of resolving power quality issue and also reduction of CO2 emission. And that is we are expanding the capacity of our solar work. So that is me in Uganda, in Hoima, doing quality check in Hoima and also in Masaka. So we are deploying a stable power system for the POCR project. So they will have uninterrupted power supply, good power quality deployed during meetings, because some of all the POCR offices are focal point. It's just like what we have at the EOC in Nigeria. So this EOC, they will, when during their meetings with the directors and also some of their partners, they will have constant power supply. Devices that are installed, telecom devices, all the other devices which is being installed will not be affected due to grid fluctuation. Then the other picture you're seeing there, that is ultra -80 or ultra cold freezer. And so EOC in this location, this is Sokoto EOC. The EOC is completely off grid. They have constant power supply. So because of the outbreak of this because of outbreak of COVID-19, and they decided, okay, where are we going to have these vaccines, the COVID vaccine, closer to the people? So EHA decided to say, okay, we have constant power supply, we are not grid connected, we are not affected by power fluctuation, we have good power quality. So we now decided to accept to power this code, this -80 freezer where all these vaccines are stored. So they can deploy from here to other localities and without losing the potency of the vaccine. I think this is where we'll stop for today. If you have any questions, we are willing to answer all.
Thank you so much, Tahir and Andre, for that wonderful presentation on power quality and access challenges in low resource settings. I want to believe that we've all learned something from this presentation. We all know the importance of sustainable development goals, right? And for the purpose of this webinar, Sustainable Development Goal 7, affordable and clean energy for all, is very important. Andre talked about the causes and the effects of power quality from vandalization and illegal connections having huge cost to the society. And they both highlighted some projects that EHealth Africa has carried out, implemented. We have the polio outbreak control rooms in different African countries. We have the Meta Fridge, and we have the NCDC NRO project. So if you want to know more about this project, please reach out to Onche and Tahil. And so now we're moving on to the Q&A session. Please, if you still have questions to ask, please drop it on the Q&A box. And for the first question we have here, this is addressed to Tahil. It says, what are the limits of renewable energy as a solution to power quality? Sorry.
Hey, Omatose. So I thought I would answer the first question, which talks about unavoidable problems with renewable energy solutions. You know, by nature, wind, for example, and solar energies are highly variable, and they are dependent on atmospheric and climate conditions, right? So sometimes they can be unpredictable. So proper modeling of these uncertainties, for example, is a necessary step for renewable energy management, so that, you know, overestimations of these availability of these renewable energies is something that will be taken into account before the designs of these kind of systems. So yes, there are unavoidable problems, and these are some of the examples that I can give you today.
Okay, thank you, Tahir. There's another question for you. It says, are there unavoidable problems that can be encountered with the use of renewable energy?
And I think that's the one that I just answered now. What was the other question?
Oh, the other question. Okay. What are the limits of renewable energy as a solution to power quality?
Yeah, so again, as I mentioned, you know, proper modeling of the uncertainties that is associated with these kind of solutions is very, very important. So I will make a specific example for vaccine refrigerators. One of the protocols that is in place is to oversize solar panels for health facilities to take into account any weather conditions that may be attainable. So for example, now we are in the Harmattan season. It's very cloudy, for example, in Kano. So while Kano has a lot of sunshine and there's a lot of sun, right, we would consider Kano, you know, a good place to have solar energy. But it's very important for these kind of locations for us to take into account the Harmattan season and what is the power loss that we will experience due to the, you know, dust that can accumulate on top of the panels, right? If we take into account these kind of issues that could come and affect the availability of power and these renewable energies, it will allow us to really have a more robust system that can take into account all of these issues as we move along. So for example, one of the recommendations that is made for solar direct drive vaccine refrigerators is cleaning protocols for solar panels. So how many times should a health facility clean a solar panel when it's dusty, right? So maybe if you're asking health facilities to clean the solar panels, you know, once a month, maybe it will make sense for you to ask them to clean it twice when you're in the Harmattan season, right? So this is what we're talking about when we say this, the proper modeling of the uncertainties around these renewable energy solutions is really important in the beginning of when you're proposing to use. Yeah.
Okay, so we'll just take this next question because of time, and then would answer this later on. It's to Onche. It says, Onche, based on your experience, which region in Africa do you think is ahead of the curve when it comes to renewable energy, and why?
So I think the Northern Africa, the Egypt, and especially the Northern Africa are ahead of the curve in solar installation. And the Sub-Saharan Africa were picking up gradually, but mostly in Northern Africa, Morocco, Egypt, and they're really expanding capacity of solar installation. And also to buttress the point for Tahir said, the weather condition also affects solar power quality. First of all, if you want to install power solar system across some of the medical aid facilities, a proper energy audit is going to help to properly size the system. Then also improper sizing of the system also affects if we're having days of autonomy. We need to increase our battery back capacity, especially for regions, especially southern parts of Nigeria that experience constant rainfall. So we need to properly size and account for days of autonomy so that we can build our battery bank capacity to cater for any unwanted weather condition, and also improper sizing of our cables. Anytime we wrongly size our cable, we experience huge problem. The cable start warming up and get burnt. That affects the output of the power delivered to some of our freezers, and also the breaker sizes. Wrongly sizing of circuit breaker will affect the power quality to some of all these freezers where we are storing our vaccines. So Northern Africa, they're really moving at a high pace. Sub-Saharan Africa, we are picking up gradually. Hopefully, before 2030, we should be able to get to a level where we can have power for some of all our household. Thank you.
Thank you, Anche. Thank you for answering the question. Ridwan Lawal, I can see your question. We'll still take it, but because of time, we would like to move on to the next presentation of the day. If you're just joining us, you're welcome. Today's theme is Renewable Energy in Africa, its impact on public health and sustainable development. Moving on further in today's event, we'll be showing you a case study presentation on renewable energy projects that eHealth Africa is currently working on. Over to you.
So far, Nigeria has built about 30,000 primary health centers, or PHCs, across the country, and yet the government is lagging seriously behind in the delivery of quality health services. In 2018, the World Health Organization ranked Nigeria's healthcare system at 187th out of 190, with conflict-ridden countries like Afghanistan, Somalia outperforming Nigeria on the index. The deplorable state of the PHC system has taken a toll on the public health situation in Nigeria. A recent report showed that 1 in 13 women in Nigeria is likely to die during childbirth. The same report found out that about 58,000 women had died from childbirth complications in 2015 alone, accounting for about 19% global maternal deaths in the same year. One can point to different reasons for the dire situation of PHCs in Nigeria, ranging from fragmented services to lack of qualified medical personnel to poor infrastructures. However, amidst all this, a fundamental issue facing PHCs is the lack of access to reliable electricity. Electricity is very important to PHCs for providing water supply, temperature control for medicine or vaccine storage, basic lighting, ventilation, and clinical processes. However, Nigeria's erratic power supply has been the bane of primary health centers in Nigeria. In 2018, the Unavoidable Foundation sponsored a situation analysis study that was carried out among 60 PHCs in Abuja, Nigeria. The study found out that almost half of the surveyed PHCs could not operate beyond 5 p.m. due to unreliable access to constant electricity, meaning that they could not accept overnight admission and they certainly could not handle emergency cases at night. Meanwhile, the other half of the surveyed PHCs that could operate into the night often had to rely on alternative power source from petrol power generators and other makeshift energy from kerosene lamps, candles, and torchlight. One of the field monitors during the study reported meeting a midwife who had delivered a baby in the dark because the battery to the torchlight went dead in the middle of the delivery. The lack of electricity is coming at a high cost to PHC's operation and is also a major barrier to quality health services. Certain PHCs in Abuja were found to spend as much as 500,000 naira, that is $1,300 equivalent, annually on petrol power generators, which are often paid for out of the pocket of the medical personnel, and charges from health services that could have been offered for free. Meanwhile, PHCs that could not afford to run petrol power generators could not appropriately store vaccines, and they also lacked clean portable water. So far, we have highlighted the problems faced by PHCs because of little or no electricity. What is then the solution? Standalone solar power solutions have great potential to provide access to cost-effective and reliable electricity for PHCs, especially the ones that are situated in low-income areas and away from the national grid. A study done in India showed that a solar-powered health center treated 50% more patients, conducted 50% more safe deliveries, and operated round the clock. In Dakwa, Abuja, Nigeria, a solar-powered PHC is already operational, which has been responsible for providing round-the-clock health access for the semi-urban populations on the outskirts of Abuja. The solar PV system has been running since 2016, thereby increasing the patronage from almost zero to about 100 patients a month. As a 2018 study has shown, there is an economic argument for installing solar-powered solutions in at least some of the existing PHCs in Abuja, especially if you consider how much is being spent by PHCs for electricity supply. The study found out that PHCs are already spending between 23,500 naira to 48,000 naira a month, enough to cover the bill for just 4 hours of grid electricity plus an additional 6 hours of running generators daily. If you do the math, the bill adds up to about 500,000 naira, that is $1,400 annually for just about 10 hours of electricity every day. Not nearly enough to meet the minimum set standard of running a PHC, meaning that each PHC needs as much as 900,000 naira, that is $2,500 a year if they are to meet the standard of 24 hours access to electricity. This is almost 5 million naira, that is $14,000 within the space of 5 years for just one primary healthcare center. At this point, it is important to know that installing and maintaining solar solutions will cost a fraction of that amount over the same period of time. The cost of installing 3 kilowatt solar solutions for a PHC is about 2.5 million naira. From the get-go, it seems like an enormous amount, but when you consider paying almost 900,000 naira annually for grid electricity and maintaining power generator, compare that to the almost zero annual cost of maintaining a solar system, you will begin to appreciate the economic advantage of solar-powered PHCs. However, it seems that the FCT administration is not aware of these arguments, but rather focuses on establishing new PHCs, usually driven by political motivation, instead of the actual needs of the communities. And this is the primary reason why about 80% of the health centers in the country are not fully functional, because a lot of these so-called PHC buildings do not have equipment and staff. Between 2014 and 2015, over 91 contracts to the tune of 2 billion naira or $6 million equivalent have been awarded to build new PHC buildings. And according to these reports, dozens of these buildings have remained unused. This 2 billion naira could have easily been spent on providing standalone solar systems to about 1,000 PHCs across the country in 1 year. Funding. A key factor to consider in providing solar solutions for PHCs has generally been inadequate in the Nigerian health system, and the FCT makes no difference here. The percentage of the budget allocated to health has been dropping consistently for the last 3 years, from 4.23% in 2016 to 3.95% in 2018. Further analysis of the budgetary allocation to Abuja PHCs reveal that only about 66,000 naira, that is $180 equivalent, annually is made available to cover the cost of electric bills and maintaining power generators for each health center. A far cry from the 576,000 naira or $1,600 equivalent incurred by some PHCs. However, to solve this funding issue, increasing the budgetary allocation for primary health care by the Federal Ministry of Health is the obvious thing to do, but the Primary Healthcare Development Board in Abuja, FCT, needs to start giving special financial consideration to providing solar-powered solutions, especially during the construction stage of the PHCs, of which have been costed between 10 million naira to 40 million naira in the national fiscal budget. Ultimately, the Federal Ministry of Health should make it mandatory for PHCs to have solar-powered solutions as a minimum standard, thereby obligating the Primary Healthcare Development Board to provide solar systems for PHCs. Investment into solar is a no-brainer because at some point, the cost of solar energy becomes neutral. This is when the avoided cost of buying petrol and paying for grid electricity becomes equal to the cost of the solar investment. After that point, electricity is for free forever. The problems facing the primary healthcare system in Nigeria may be complex and would require a concerted effort to solve them, which could span over a long period of time. But something could be done right now to ameliorate the problem in the short term, and this is simply improving access to electricity for PHCs through solar energy. This action would definitely improve the quality of healthcare in the FCT and across Nigeria. This could save the 58,000 women that die yearly from childbirth, as well as the 2,300 kids under 5 years that die every single day.
Okay, thank you for that presentation. I want to believe that that video has given each and every one of us something to think about. And we hope that from that video, you can start thinking of ways that you can individually contribute to affordable energy and renewable energy and making sure that everybody has access to it. So moving on further in today's session. Next on the agenda is the panel discussion. This session is focused on renewable energy and strengthening healthcare systems, making the connection. So this session, I would like to welcome the moderator, Dr. Usman Mohammed Ibrahim. Dr. Usman Mohammed Ibrahim is a consultant, public health physician, a fellow of both the National Postgraduate Medical College of Nigeria and the West African College of Physicians. He's currently working with the Department of Public Health, Jigawa State Ministry of Health. Please welcome Dr. Usman, and you welcome other members of the panel.
Good morning, everyone.
Morning.
So it was actually a wonderful hour spent well, and I believe all the participants have heard and have seen what is happening to us. And at this point, I want to believe that we need to know the concept of different types of economy. Looking at the video, looking at the discussions, looking at the presentations by all the participants, permit me to bring into this forum the difference between linear economy and circular economy. Linear economy is such economy that you actually develop without thinking of the future generation. While when we are talking of circular economy, is that type of economy that is developed looking forward and backward, thinking ahead of time, and working towards ensuring that whatever you do, the future generation stands to benefit from the available resources. And that is a concept of sustainable development. You develop, and that development should be in sustainable format. Backward, during the presentations, I believe the participant must have heard of a lot of issues related to power quality, effect of power, poor power quality, and permit me to also add to the concept of power quality issue. You know, we have heard of accountability, poor accountability framework, and that significantly involves the consumers. However, you agree with me that from the other end, we have a problem with accountability mechanism from the provider side if we are talking of the grid, especially in the developing countries. More so, you agree with me that we are increasingly, population is increasing in a geometric fashion, not in arithmetic fashion. Meaning that we have available power to serve a particular number of people, but within a span of a short time, you see a significant increase in population. And that means that the power will not be available to serve all the people, the people. And additionally, from the other end, if we look at the effect of poor power quality, I've not, you agree with me that alternating voltages can result in a lot of death, can result significantly in the loss of resources, so many resources. Additionally, you agree with me that when we are talking of health system, and we are talking of health system strengthening, services delivery is one of them. And I have heard one of the presenters talking about closure of health facilities as early as 5 p.m. And you also agree with me that most of the cases, particularly maternal death, particularly under 5 mortalities, occur most at times at night and occur most at times due to poor access to care. And you agree with me that once a facility is closed by 5 p.m., the danger hours that start after 5 p.m. are significantly lost and lives will be lost for sure. And also, I want us to understand that healthcare workers may not only human resource for health is one of the components of the health system. Better health. Hello? Hello? Can you hear me?
Yes, Dr. Usman, we can hear you.
Okay. Not only the inability of health, the facility to function, health infrastructure. The infrastructure forms one of the components of the health system, but not only the functionality for 24 hours. You agree with me that the human resource for health at some point during the year, it's very difficult to work in the health facility without electricity, simply because poor ventilation, hot weather, and other confounding issues. So also during the conventional, we assume that 9 a.m. to 5 p.m. is the conventional working hours. When there is no good power supply during the morning hours or during the so-called conventional hours, also the health workforce may not function effectively to provide quality health services that can result in better health outcome and increasing or improving our health indices. Also, not only vaccines, most of the refrigerators, solar powered refrigerators we have in the health facilities, especially at the lower level, that utilizes solar. We also have medicine and other products apart from the vaccine that requires good power. And of course, you agree with me that most of the drugs, when you check, they give you minimal temperature required for ensuring the shelf life is maintained as indicated by the manufacturers. And also the healthcare financing, the clip we listen, the clip we watch, you also agree with me that it affects the healthcare financing. It can also influence the healthcare financing. You agree with me that when you have significant input. You have a business, you invest, you put so much money into that business. Then, of course, for you to sell out your services, you need to increase the services. You need to increase the cost of the services. And that can actually go down to affect the larger consumers. We tend to forget that we have two sectors. We have public and private sectors. And even the private sectors charges their customers based on the spending they have to put in place all the required health workforce. For the community participation, which is also an additional component of the health system. Of course, when you have poor health indices from the available health facilities, and these poor health indices are traced to poor quality of the services provided. Of course, the community members may tend not to patronize the healthcare services, and that can actually continue to worsen the health indices. So tying off all this discussion, you agree with me that the presenters have done justice to the presentation and have actually tried to bring out the pressing need to have an alternative power source, pointing clearly that we have effect to even the power we have power meeting significant number of people. We have large population growth, and in such in that way, some people still don't get that power. We have the power, but the quality of the power is affected by so many factors. And of course, what do we do to tackle that factor? And we have an alternative, and this alternative is using alternative sources of power. We have renewable energy, and of course, solar power is one of the renewable energies that is very popular now. We have other sources of renewable energy. We can use biofuel. We can also use wind to provide an alternative power source. However, solar is the one readily available and commonly used, and for sure is more affordable at the moment. So thank you all the presenters, and for the participants, I hope the discussion has actually been fruitful. And of course, we look forward to hearing more questions, more suggestions, and how we can actually improve, or how we can have better solution to this problem. Thank you very much, and over.
Thank you, Dr. Usman, for those salient points. We're happy to hear conversations like this. Because this was supposed to be a panel session, we would like to invite the remaining panelists. Please, we would like to invite Stanley. Please, I apologize in advance for murdering anybody's name. So Stanley Omunuma, who is from Rural Electricity Agency, would like to also invite Oluwatobi Shoyombo from Haven Hill, and then Dr. Ifunanya Ilodibe from EHA Clinics. Please, we would like to invite 3 of these panelists to share their contributions. Yeah. We can start with Stanley.
Good morning, everyone. Like she had said, thank you so much for the introduction and everything. So like she has said, I'm Stanley Owunuma, and I work with the Rural Electrification Agency as a project manager for the COVID-19 and Beyond initiative under the mini-grid component of the Nigeria Electrification project. So I'm the one that manages the program design and smooth implementation towards providing clean, reliable, and sustainable power supply to healthcare facilities. And I have actually, sorry that I joined late, but from the little ones that I met, I can see that we are all on the same pace. So I don't know, should I go ahead with talking about my agencies and what?
Yes, you can. You can start with what REA is currently doing in the country, and then we'll move forward from there.
All right. Yeah. Thank you. So as we all know, REA is currently an implementing agency that is saddled with the responsibility of providing electricity access to underserved and unserved community. So, but unfortunately, with the emergence of the COVID-19 pandemic, the REA developed the COVID-19 and Beyond initiative which is split into two phases. So the COVID-19 and Beyond initiative is actually a sub-component, for those that are familiar with the NEP, it's a sub-component under the mini-grid components of the NEP. Like I earlier mentioned, the NEP is a Nigeria electrification project. So this aims to provide clean, reliable, and sustainable power supply to isolation and treatment centers, and likewise the primary health centers. So the COVID-19 and Beyond initiative is split into two phases. So the phase one is to actually power the isolation and treatment centers, while the phase two is concentrating on powering 400 PHCs. Also, the REA has actually deployed solar power solutions to over 196 primary healthcare centers out of the 200 proposed under the Economic Sustainability Plan intervention program. So in 2020, in March 2020, at the peak of the COVID-19 pandemic, the REA was able to quickly deploy a 53.1 kilowatt system to the University of Abuja Teaching Hospital, and 25 kilowatts peak solar system to the NCDC laboratory in Lagos, and a 10 and 20 kilowatt peak systems respectively to the Ikenda and Ibeker, sorry, forgive my pronunciation, Ibekerodu isolation centers, all in Ogun State. So the REA, like I have said, on the two phases, which is the phase one and the phase two, for the rapid response that they did to build a pilot, that was what really led to them coming up with the intention to power the 100 ITCs, and that is seriously on the developmental stage. But for the 400 PHCs, it's still very much in the preliminary stages of development, because there are a lot of processes involved, and I'm happy that I had a lot of the presentations indicating the effects and the importance of proper designing. Yeah. Thank you.
Thank you, Stanley. We do appreciate your contribution and letting us know what Rural Electricity Agency has been doing over the years. And so I would like to invite Oluwatobi now to talk about how private and NGO sector can collaborate better to provide renewable energy options specifically for the health sector.
Thank you very much. Can you hear me clearly?
Yes, loud and clear.
Thank you very much to EHA and other partners for putting this program together. The subject of healthcare is very, very important in Nigeria and across the world. I mean, without a quality healthcare system, I don't know how we all can survive. And it's unfortunate that when we talk about healthcare, especially in this part of the world, more attention is always placed on the private healthcare system, which we all on this call benefit from, but very less is often talked about when it comes to the primary healthcare facilities and the healthcare system that the masses across the country are supposed to benefit from. So I'm very happy to be part of this conversation because it's a very important one, and hopefully the right set of people are listening, and hopefully some of the changes that we all want to see will be affected when they hear the outcome of these conversations. So we are an energy access company, Living New Synergy. So we believe in the power of the sun in empowering Africa's most displaced communities. So we have our operations both in the urban areas as well as in the rural communities. And as an energy access company, energizing healthcare facilities is very, very, very important to us. We actually launched our Energizing Healthcare initiative in 2018, though with a private hospital in Lagos, with a 40 kilowatt system, which is still running to date, and which is actually about to be scaled up to, I believe, 140 kilowatt early next year. And this year alone, we have electrified 21 primary healthcare centers in your state, and that was funded by Power Africa. And I'm happy happy that that's one of the things that you want me to talk about, because at the moment, from what the previous panelists and the two gentlemen that presented earlier on showcased, it looks as if the funding that the primary healthcare facilities now is quite limited. Not only in the area of electrification, but even in the area of the medical equipment and the medical supplies and other operational stuff that needs to be put in place for a primary healthcare center to actually run efficiently and effectively. So that's why, at the moment, in my opinion, I believe that the non-government organizations and other similar stakeholders are the ones that have been filling the gap for the government. So, for instance, the 21 primary healthcare centers that I mentioned that we powered this year was actually funded by Power Africa under the USAID organization. So, and I think that's sort of my apologies, sir. All right, I believe that kind of partnership is actually very, very important in electrifying healthcare facilities in Nigeria. Now, there are a few questions that I want to ask, and these are just open questions that needs to be answered, especially when it comes to the electrification of primary healthcare centers. For number one is, what sort of business model are we talking about? So we've all agreed, I believe all healthcare practitioners on this call, at least by now, will already agree that solar is effective in electrifying healthcare facilities. But then, so which means we do not have a question of technology. We do not have a problem with technology. We have now accepted that the tech that we have right now can solve our problem. Then the next question we should be asking ourselves is, what sort of business model should we be adopting? Right. In the past, one of the reasons why solar, I mean, there are several options, which I'll just go quickly. There's the EPC option, which is the government just awarding contracts to private companies just to deploy solar, and then the answer after deployment, right? And then there's the energy as a service, which is that the facilities pay per whatever they consume on a kilowatt hour basis, and then there's power as a service, which is just a flat fee on a monthly basis. But now each of these models have its own challenges, right? If you talk about the EPC, I mean, that has failed us so far, right? We've had several contracts that have been awarded by the government to build, not only in the healthcare space, but generally speaking. If you live in Abuja, for example, you will see all kinds of solar-powered cameras that were built several years ago. Majority of them are no longer functional because those projects were awarded as EPC, as contracts, and once the contractor is done, the hands off, and then that leads to a question around sustainability, which is very critical. Then when you talk about energy as a service, which is a model where the government pays nothing. Ideally, this is the cheapest option for the government because there is no capital cost involved. The government only has to identify the primary healthcare centers that need to be electrified, and the private companies then go in and then deploy the system. But now the question is, when the private company goes in to deploy that system, how does revenue collection happen, right? So who pays the bill on a monthly basis? We've had on this call that doctors actually sit down sometimes and actually pay from their pockets for the cost of rolling generators. So which means that how do we ensure that the government honors that obligation to make their monthly payment? And the same challenge also applies to the power as a service model as well, because it requires a continuous payment for maybe minimum of 10 years. And these two options, energy as a service and power as a service, are the most sustainable options that all primary healthcare centers and that the government should be jumping on. But the major issue with that model is the ability of the government to honor its own contract. So now, because of these challenges that I've just highlighted, and because we can no longer wait for the government to just to fill in the gap, that's where we have the NGOs at the moment who are currently filling the gap, because I mean that it's their own that is part of their own mission, to ensure that quality healthcare across Africa. So what we've seen the NGOs do now is to form an alliance with the private companies to just sort of deploy whatever each of those private companies are comfortable with. That there are some who are comfortable with EPC, we just want to deploy and maybe just sign an O&M agreement such that the system is not there, the system remains that of the government. but they sign they sign a 5-year contract or a 10-year contract to continue to manage operations and to ensure that the systems continue to run for at least the next 5 to 7 years or even 10 years. And then we also have companies like ours who prefer the power as a service model. So where the capital expenditure of the system is funded by the NGOs, and then we then sign an agreement with the NGOs, that covers us the system for about 10 years, and at the same time also sign an agreement with the government to make a monthly payment. I mean, these systems are still new because those were deployed this year, so it is yet to be seen whether the government is going to honor their own commitment. But I would like to let you know, as I wrap up my thoughts now, that in a situation where you have a government that is willing and ready to honor commitments, and the easiest way to show that you are able to honor commitment is to be able to give a guarantee. There are several forms of guarantees that the government can issue, and which doesn't have to be a sovereign guarantee. There are irrevocable standing payment order that can be signed. There are several forms of financial instruments that the government can issue to show their commitment. And if in a situation where you have a state government that is willing to sign such agreements and that is willing to put such instruments on the table, I make bold to say that the private sector in Nigeria today are willing to ensure that all primary healthcare centers, but I mean, there are about 30,000 primary healthcare facilities in this country today. I'm telling you right now that if you have a willing mindset from the government, I'm telling you that all of these facilities are going to be electrified. The reason why they're not electrified right now is because the private sector are always going to think about the commercials, right? Even if we're not going to make profit because it's a sacred industry, we have to at least break even. But if you imagine you talking to investors and and we do that a lot. We pitch to investors for all of this, for all of our projects. And the first question an investor is going to ask you is this profitable? Yes, if you can show on a model that is profitable, they would be interested. But then the next question is the payment risk. Yes, I can see in your financial model that this project is profitable so long the government pays. But what I don't know is whether this governor is going to win the next election. And this governor is, or maybe you have a governor that is even that is at the end of his second term. The question is the next government going to honor that commitment? Then they ask you for a payment guarantee. So right now, and one of the ways that maybe the NGOs can also help is maybe by kind of putting together a program that sort of puts a guarantee on the table. Because yes, grants are important, but I'll tell you today, if a project is commercially viable, you do not need grants. If a project is commercially viable in such a way that the payback period is short, in such a way that there are no payment risks or there's a guarantee such that if the contractual party defaults, the private company can call on that guarantee, then trust me, you don't need grants. So maybe part of the funds that are being pumped into donations and grants to deploy solar systems, maybe some of them can also be deployed in some of the private companies can call on. So I just wanted to wrap up my thoughts that this, in our opinion, as a private practitioner in the space, we believe that the reasons why these projects are not yet why we cannot see all our primary healthcare centers with blue roof with the panels on top of them is simply because of the risks that exist. It's not a capacity issue. It's not a technical issue. It's nothing. It's simply a question of the payment risk. And if we can have an extensive conversation on that. And maybe I don't know if there are government representatives on the calls that we engage in providing a lasting solution for this. But at least for now, kudos to all the NGOs that have been supportive. Kudos to Power Africa, Shaw Foundation, and others that have been supportive in ensuring that these healthcare facilities are electrified. For everybody listening to me, all I've just said is gibberish. All of the panelists have just said right now on this call, you will not understand. It sounds like gibberish to you until you have a pregnant wife who has to deliver a baby in the bathroom. Until you have, and if you're a woman here and you don't understand, so imagine you about to give birth in a room that does not have any form of electricity. Imagine somebody bringing a kerosene lantern to you to deliver your baby, that you cried for 9 months. And imagine all the risks that could potentially, and just imagine potentially go wrong. So that's what we're talking about here. So, and nobody prays that on himself. And that's why we all need to continue to work together to solve this problem and ensure that all our primary healthcare centers are all electrified. Thank you very much.
Thank you very much. Thank you very much. May I invite Dr. Ifunanya from eHealth Africa Clinic, please?
Hi, good afternoon, everybody. Can you hear me?
Yes, we can hear you very well.
Excellent. So my name is Dr. Ifna Iludibe, and I actually work at EHA Clinics, which is a subsidiary of eHealth Africa. And just to tell you a little bit about EHA Clinics, we like to call ourselves Primary Healthcare Plus, because even though we're really focused on primary healthcare, we also offer some secondary services like our dental and eye clinic services. It's just been very interesting listening to the moderators and the other panelists. So thank you so much for having us. And it's really an honor to speak on a panel such as this. So when I was listening to some of the discussions about if you are a woman who has to deliver in certain conditions. So let me just start with a funny story. So during my NYSC, I actually was deployed to a primary healthcare center, and it happened to be an EPIC center, which meant that we provided services to women who had tested positive with HIV. And for those of you who are medically inclined, when patients are in labor and have HIV, we usually do not conduct something called spontaneous rupture of membranes. This is just to limit exposure for the baby, even though the woman is taking medication. So I remember this delivery that we had to conduct, and we actually did the delivery under candlelight. And I remember very funny that the baby came out in the amniotic sac and almost slipped off the bench because we couldn't see the baby. So what we're talking about is not conjecture. These things are actually happening, and doctors are actually practicing under these conditions to bring healthcare close to the people. And I'm just going to talk a little about, even different experiences I've had as a physician. I remember the last hospital where I practiced. It was a fertility hospital, and we have incubators where we keep human embryos. And in those situations, your power is not allowed to go off, which meant that we couldn't even rely on the power from NEPA because it was coming in, or from the what it's called now, because it was coming at a really low voltage, which could destroy the machine. This meant that 24 hours a day, 365 days a year, as long as we had patients with embryos in the incubators, the generators were on. So you can imagine the huge cost of maintenance and generator fuel. So at EHA clinics, we're lucky enough to practice in a setting that cannot be termed as low resource, but there's still a lot of energy challenges. And with anybody who's practicing in Africa, of course, having to rely on the power from the national grid, which, in Abuja and in this area is pretty decent. But of course, in an organization like ours, and Onchi has spoken very extensively about some of the things that we've put in place. As we run COVID tests, we cannot afford for the machines to go off. If not, we lose that entire batch, and we have to resample clients and rerun those tests. So having to backup power systems in place, inverter systems in place to ensure that the machines do not go off. Also deployed a few, partially off-grid systems in our Asokoro site where it's partially off the grid. So we run that facility completely on inverters, inverter ACs, inverter fridges, which have low carbon emissions. And of course, we've been able to do that for over a year successfully. Just to wrap up, a few of the other things that we've deployed at EHA clinics in Abuja is our solar water heating system. So when our patients on admission, we don't have to install like multiple heaters in different rooms so that patients can have hot water that is comfortable for them. We actually have a solar water heating system that not only supplies the main clinic where we have
Dr.
admission
Ifunanya,
rooms. Yes?
sorry to interrupt you. Sorry. Dr. Usman, please, can you go on mute, please? Thank you. Please go ahead, Dr. Ifunanya.
No problem. So I was just trying to wrap up. So I was just saying that we have our solar water heater system, which not only supplies the main clinic, but also the COVID-19 isolation center, which is also located on the premises, but in a further distance. So EHA Clinics has, tried to bridge the gap to make sure that when patients come in, because we're open 24/7, we cannot afford to close because we have inpatients. And of course, it comes at a huge expense. And I believe that being able to use renewable energy will be able to drop those expenses so that we can even afford to drop our costs and have more people access high quality care. So thank you very much. And it's a pleasure once again to meet all of you.
Thank you very much, Dr. Ifunanya, for those points. Interesting conversations that we're having now from all the panelists. And we have amazing questions from participants online. Ridwan Lawal is asking Stanley how the REA has been empowering MES startups to help improve democratizing access to clean, stable, and sustainable energy to low-income areas and primary health centers. Also, can you walk us through a process of getting REA backing? Stanley, did you hear that question?
Yeah, thank you for the question. So, like I said earlier on, in terms of empowering the MSMEs so for the 400 PHCs, we're trying to build up a structure that can, create a platform for the best possible way of, improving and empowering the healthcare centers. Then for the Herculean task of trying to tap into NEP. So I just don't want to go deep into, all the process of NEP because this program is centered on the health care facilities. But for NEP, we have like 3 major components, which are the mini-grid components, the SHS, that's the solar home system, and the energizing education. But the COVID-19 and beyond sub-component is under the mini-grid component, which is also, like I said initially, split into 2 phases. The phase 2 is very much in the preliminary stages, the stage of site identification, and before we can go into deep energy audits and designs. So within these processes, I believe it is open to the intending members who want to register to NEP or getting the criteria on trying to support and then be part of this dream of trying to ensure the health facilities are powered.
Okay, thank you, Stanley. So we have another question here from Oluwaseun Shodikwe. Also to you again, Stanley. Did the REA collaborate with the SCHCDAs for the deployment of renewable energy sources to PHCs? I think this is a 3-in-1 question. So what selection?
If I can get the SPHCDA should be like the state primary healthcare development agencies, right?
Right.
Yeah, so Rural Electrification Agency, actually, with our mode of operations, we actually don't play with engaging all necessary stakeholders. So for the list of the 100 sites that we are currently developing under the phase 1 of the COVID-19, it was actually provided to us by the key stakeholders, which is the Ministry of Health. Then for the PHCs, we've actually, have a good collaboration with the National Primary Healthcare Development Agencies, and they've provided REA with a pool of sites where we can now carry out the necessary studies to identify and select the sites that are viable according to priority. So that is it. So we engage all necessary stakeholders in our deliverables.
Okay, thank you very much, Stanley. The next, I'd like to say, please, if you have more questions, please use the chat box to the Q&A box rather to send you your questions. We have three amazing subject matter experts on the call. So please, this is the time to ask your questions. Yeah, I have a question for Dr. Ifunanya, and it says, are there any excess renewable energy generated by EHA clinics that can be supplied to nearby public healthcare facilities?
Hello, I hope you can hear me. So as it stands right now, at EHA clinics, we do not have excess renewable energy that we can, because for the most part, at EHA clinics, we still depend on the national grid, and we also have backup generators, which is not renewable energy as described. So right now we don't have that capacity, but it's something that, I mean, in the future, it's something that we can think about. But right now, no.
Okay, thank you, Dr. Ifunanya. I have another question for Oluwatobi, and it is, are there any successful national or subnational level health facility electrification programs that can act as a case study or blueprint for other countries?
Thank you very much for that question. I mean, I think the one from REA that Stanley mentioned earlier on might just be the first one that could be a lesson or a kind of case study for other countries. We are also part of that, and I'm also aware that there are a few states that are currently. There are a few states, so this should be at the state level, not national. There are a few states, I believe, Kaduna, Kano, have been quite active in that space, but I don't have the full details. So, but maybe those are also good. But I've been in sessions where those case studies have been presented about how they are electrifying some primary care centers in those states. The one we did was with Oyo State, and I believe that's also a very that will also be a very good case study, though it is still early. As I said earlier on, the deployment happened just this year. So hopefully early next year, we ourselves might put out a case study or a white paper just highlighting the process. And I saw someone asking about the selection criteria of the healthcare facilities that we electrified. All of those things are hopefully, if we put out that white paper, we will document all of those things there just for others to learn and also the things that the others need to be careful of with such programs. But for now, those are the few ones that I can mention.
Okay, thank you, Oluwatobi. Just to go back to you again, right? Are there any other innovative financing models or options to help power healthcare facilities with renewable energy aside from donor funding?
Absolutely. Yeah, sorry. On that topic, I personally believe that if you want to solve any problems, of course, apart from the infrastructure and the policy and all of that, talk to the funders. They would, if it makes sense to them, they would always find all sort of instruments to fund it. So one is the model that I mentioned earlier on, right? So where you can, a private company can actually put in his own equity with a combination of debt. So which is how most projects are funded. So, but unfortunately, it will be difficult to do that for one primary healthcare center because you'll be talking about maybe, 10 to 50 kilowatts. In fact, in most cases, most primary healthcare centers would probably need between 10 to 20 kilowatts because of the kind of equipment that they want to power. So it will be difficult to get a bank or a large funder to fund you, to just fund 2 million or 3 million naira as the cost of deployment, because the same effort you need to fund 2 million naira is probably what you need to fund 200 million naira. So so a good approach would be to bundle maybe 10 or 20, maybe even 50, maybe 100 in a state or across multiple states in a single portfolio, and then contribute maybe about 30% of debt on the private company side, and then you can then leverage, of equity on the private company side, and you can then leverage 70% from either a bank or any of the other finance houses, and they'll be happy to fund it if it is financially viable, and especially if you can get the state government to give a guarantee on irrevocable standing payment order. If you have that in your hands, I can almost tell you that your bank manager will be willing to have a conversation with you, or any other infrastructure debt fund in Nigeria, and there are quite a number of them now that will be willing to fund. So not to downplay the role of grants completely, especially in a space where the governments are still not fully on the table. So grants are still important in that kind of space. But in a situation where the government shows willingness to honor their commitments, their commercial obligations in such a contract, then yeah, we might just stop talking about grants, and we let grants go into other places where they are needed the most. But before I stop answering this question, I also need to mention that equipment in those primary healthcare centers are critical. So we are talking about electrification now, but one of the challenges that we face, one of the things that we saw when we were about to deploy, was that some of those facilities were not adequately equipped. So you had cases where you deployed 10 kilowatt system, but the facilities were barely consuming maybe half of it. And when you check what was connected to it, it was just TVs and lights and just normal stuff that you use in your house. So we also need to have conversations around how do we get those facilities equipped. Of course, I know that maybe why they were not equipped because there's no electricity. But now that we're having that conversation around electrification, that conversation should also go hand in hand with equipping them. Maybe that grant, if the state government is willing to come to the table, maybe the grant that was supposed to go towards electrification, maybe that could then go towards ensuring that those facilities are well equipped.
Thank you, Oluwatobi. Your first reaction was very interesting.
Thank you.
All right, Dr. Usman, do you have any thoughts to share about what Oluwatobi just mentioned, looking at it from the government's perspective?
Hello. This is actually a very interesting discussion, and I think from the government side, I think one thing to ensure is adequate sustainability plan for whatever project. Of course, the presenters have tried to identify the political activities, changing in government, among other things. So I think across all the presenters, I think of importance is a sustainability plan. We should have on board a very good mitigation plan. We may have additional problems apart from political issues and government changes, but also when we have in place, for example, even the accountability issue. You may have electrification in the facilities, but of course, for solar-powered electrification, of course, requires a lot of investment, resource-wise. And of course, if you don't have an approach, a way to ensure that they are safe and are safe, then it's also something very, very important. Also, I think if the program is on board, I don't know whether it's a point for discussion by everybody. I don't know whether when we have an MOU, or any NGO going to support the government for electrification activities, then in a situation whereby the agreement is taken to the House of Assembly, I don't know, I'm just thinking ahead, and maybe if that can be a kind of law, sign law, so that it is binding by anybody coming to actually ensure that what was signed by the previous government is actually implemented. So I think this way, it can help a long way. And for rural electrification, I don't know whether there is actually any target set. One thing I heard from his end was they have a plan to electrify, isolate. They have started with the electrification centers in the first phase of their intervention. And then later they will go onward to electrify the primary health facilities. So I don't know whether they actually have targets, and they also, they have indicators and they actually have a time frame of achieving the plan. So this is my take, and looking forward to discussing along the line. Thank you.
Thank you, Dr. Usman. Please, before you go, I would like to hear your final thoughts on how stakeholders can work together to stimulate investment in renewable energy.
Hello, please, can you come again?
Yes, so the question was that how can stakeholders work together to stimulate investment in renewable energy?
Okay, I think of importance is advocacy. When we advocate and we try, you see, when the video highlighted earlier was actually very, very critical in identifying the problem. I think it was actually well done. And I think when we find an appropriate technique of advocating to the stakeholders, we know who are our stakeholders at higher level. I don't know whether bottom-top approach will help, but of course the policy makers need to be on board. They should be appropriately advocated to. And of course, when we have something like that video, and when we take it at a very good time, that very good time in the sense that they give us a good audience, and they understand the implication of what is on ground, and the importance of what we intend to achieve in the future as far renewable use of renewable energy. For example, the clip tries to highlight the cost of fueling generator, cost of maintenance, and of course, it didn't even capture the ill effect of the gases produced as a result of the use of generators, not to even talk of the money. So if we can advocate in a better approach, and of course we follow up, advocacy alone, most of the people present here can believe with me that advocacy once is not enough. We need to actually do it and sustain the tempo towards achieving what we intend to. So I think this can go a long way. We advocate and we sustain the tempo towards ensuring that renewable energy is used in the health sector. Thank you.
Thank you so much, Dr. Usman. We really appreciate your comments about all these questions that we've asked you today. And so I would like to ask Stanley the same question. The question is, how can stakeholders work together to stimulate investment in renewable energy? So please, in 1 minute or less, please go ahead.
All right, thank you so much. Like I said from the onset, that REA, in terms of delivery, they ensure they engage all the necessary stakeholders. So we've had a series of situations where different bodies have different developmental strategy for these PHCs. So what we want is that they should just come together and come up with what they need to give to these PHCs for development. If they want to build infrastructure, if they want to provide medical facilities, if they want to electrify. So everybody should be in synergy to ensure we achieve a common goal of ensuring that, one, the sustainability of the system and the provision of all the necessary infrastructures needed for the normal operation of the PHCs.
Thank you, Stanley. Oluwatobi, same question.
Can you hear me?
Yes.
Yeah, I think it starts with forums like this. I think more of these conversations first of all will need to happen. And then, I imagine that the stakeholders we're referring to are the government, private sector, as well as the donors. So I think on the donor side, the donors will have to, in my opinion, I won't wait for the government, right, to initiate that conversation. I would say that the conversation should be initiated by the donors, by the non-governmental bodies that are interested in the space, and that could be in the form of even before the call for proposal or any of the things, because we've seen several people who just call for proposals after they finish designing their program, but unfortunately at the end of the day what they've designed is not even what the space needs. So I think a cross-sectoral conversation needs to be had first before those call for proposals or before those initiatives are designed on the donor side. And that's because for now, the donors are more active in the space. And by donors, I mean, and maybe also since we also have some government agencies as well now that are also beginning to play that donor role, because anyway, government money is more or less like how do I put it? In some ways, it could also be grants, as RE and NEP has been doing. So maybe before those programs are also designed by from RE and other governmental agencies that are concerned about the space, deep conversations will need to be had by all the stakeholders. We need to get the primary healthcare workers as well involved in this conversation. So we need to understand what their needs are for those who are not yet electrified and who don't even have equipment. So maybe some of those initiatives should be designed alongside the provision of equipment. It has to be a broad conversation. I think that conversation will need to start from the donors. Our role as private companies here is that we need to continue to talk more, because I agree fully that one of the presenters mentioned that we don't even have data to even reference. So I agree that maybe private companies that are already active in the space as well should talk more, should also put out this data, whatever their experiences have been in electrifying those healthcare facilities. So we need to bring those data and those experiences on board as well, just to help both the government and the NGOs design a better program. So so thank you. Those are my thoughts on that question.
Thank you, Oluwatobi. Thank you. I would like to appreciate all the panelists for joining us today and for all the answers they provided to the questions. Really appreciate everyone. And so we'll be going on a break now, and for 3 to 5 minutes or thereabouts. We'll reconvene by exactly 12. So we've been sitting for almost 2 hours. So take this time to stand up, stretch, drink water, and then we'll reconvene by 12. Thank you. Hello, everyone. Welcome back to today's event. We're so happy to have everyone online join us. My name is Omotoyasi Ajishomo again, I'm a project coordinator with eHealth Africa, and today's theme has been renewable energy in Africa, its impact on public health and sustainable development. So we took a quick break. Welcome back, everyone. Somebody said, I did not say they should take tea. Please, I hope you have tea by your side or water, whichever one is your preference. So thank you and welcome back to today's event. So next on the agenda is the last presentation of the day. It's the presentation on renewable energy as a lasting solution to the lack of access to power in rural health facilities. And then we'll have for this presentation representatives from Integration, Environment and Energy, GMEH. We have Mohammed Emran, who is the project manager. He has an MSc Renewable Energy and Management. Mohammed Emran is passionate about the promotion of sustainable energy solutions in rural electrification context. His key areas of expertise are system design and modeling of distributed energy systems. And then we also have Oscar Monet, also a project manager from the same organization. Oscar is from Barcelona and holds an MSc in Renewable Energy and Energy Innovation from the Royal Institute of Technology, Stockholm. His main areas of expertise are rural electrification in developing countries, particularly through solar technologies. So I'd like to welcome Mohammed and Oscar for their presentation.
Hello, good afternoon. Thanks a lot for the introduction. And on behalf of Integration, I would like to, first of all, thank eHealth Africa and all the organizers for having us on board. We're absolutely delighted to be here and given this opportunity to share our insights on this interesting and very relevant topic for today. As you kindly mentioned, I'm here with my colleague Oscar today, and we will walk you through the next 45 minutes with some ideas on how we can look at the sector from a holistic point of view. And I think something that I can say upfront is that based on the discussions and the presentations that were made so far, we would like to bring in a slightly different perspective. I would let my colleague Oscar present our company as well, but Integration is primarily a consulting company, and therefore we come from a slightly different perspective and to look at how we can facilitate and support the government organizations in Nigeria as well as the private sector to really facilitate upscaling or a growth on a sector-wide level. And for that, we were going to share some insights on that. So we'll start by talking about our experience in Nigeria and in the renewable energy sector. We would then briefly touch on some energy topics in the health sector. A lot of has already been spoken. And then we would like to dive into a case study on how electrification planning approach that incorporates these health facilities can help to bring synergies into this and wind up with some key considerations to lead into the discussion. With that, I would like to invite my colleague Oscar to please take it forward.
Hi everyone, thank you very much. It's a real pleasure to be here. So yeah, just to provide a bit of context on the work that we do and the different areas, I'll do a short introduction on this. So yeah, at Integration, Environment and Energy, we have kind of a global presence, especially among the global South and other countries in Europe as well. Our main idea is to facilitate development and with a very big focus in environment and energy. But the goal is to build like meaningful and especially long-lasting relationships. So as you can see here, our company is based in Gothenburg in Germany, but we have offices in Berlin, Islamabad, Pakistan, and then other representatives in China and Uzbekistan, and also like we've done quite a lot of projects in Africa. Yeah, so for example, only in sub-Saharan Africa, we've done more than 40 projects in countries like Nigeria, Togo, Uganda, Ethiopia, Kenya. I mean, the ones that you can see in the map here as well. For example, we have a set of long-lasting projects. When I say long, I mean like few years. For example, the Nigerian Energy Support Program with a focus in rural electrification and mini grids in particular, as well as the data gathering and management for electrification planning, also in Nigeria and with the GIZ as well. Other projects that we did together with the World Bank was a pre-feasibility assessment of co-located mini grids and investments in agro-processing to explore synergies between agro facilities and rural electrification of communities, as well as a geospatial assessment of mini grid potentials in Nigeria. Yeah. So the main areas of expertise that we normally work with would be, to start, renewable energies, and yeah, we have like quite a big range of ways in which we approach this. It can be like large scale renewable energy systems like grid tied, but we also have renewable energies like so small to medium sized solar hydropower projects, as well as wind and hydro solutions. And the things that we normally do here are resource assessments, feasibility studies, energy system designs, so on, as well as rural electrification planning and advisory. This is like from a geospatial point of view, can do quite some level of remote assessments that really optimize the process, as well as then moving forward with the techno-economic assessments, the energy models, and advanced data management systems. We also try to integrate renewable energies with the grid, and then to support these systems with either storage or backup generation to cover areas that might have grid infrastructure but have either weak grids or a non-reliable supply, which I think these activities can be quite relevant for the topic today of energy in the health sector, as well as a humanitarian energy. We've done like technical analysis and policy influencing, for example, to provide sustainable energy for refugee camps or host communities and so on. So I think we can move ahead. Yeah, and then like take a bit of a step further into the health sector, which is the topic today, and how energy can play a key role in it. So when we talk about energy in the health sector, especially in the context of today, we can see that there could be very different points of consumption or needs, from the smallest pharmacies that might only have like a couple of bulbs and a fan, and sometimes not even that. It's just a point for community members to procure some medicine, to basic health posts that might have already like a small fridge to store medicine or vaccines, but not like large consuming appliances, and then to bigger scale health centers, where people can already like spend a few nights. And then of course large facilities or hospitals would be the biggest, most consuming scenario, let's say. But I think it's important not to forget the smaller ones, because they're not so consuming, but maybe they are more frequent in numbers. For example, throughout the surveys that we have been doing over the past years in Nigeria, that is the most common type of health facility that we've encountered in these types of like rural or peri-urban communities. And we see that the typical appliances are bulbs, fans, and around 50% of them have small fridges as well. But yeah, it's not like we find significant amounts of high consuming power appliances. Just to keep in mind a bit this as well. Yeah. So I'm sure lots of you are already aware of energy issues faced by rural health facilities. We've even covered a few today. The most obvious one would be unreliable electricity supply, which is particularly important with sensitive appliances, like for example, the ones that were mentioned before by the doctor, like if we're storing like things that cannot be unplugged at all. This is a problem. There's also lack of night lighting. So to provide service during the nighttime is obviously very difficult if we don't have like high quality lighting. If we experience a shutdown during an operation, this can be, of course, it's dramatic. And it even means that like large bulky equipment is very difficult to transport or to repair. It takes a long time to repair. And even when things do work, because we have a backup generator, it still it frequently puts the viability at risk because of high costs, and it's not energy efficient. And then we need to be like interrupting either for voltage power surges or to repair diesel generator or to repair equipment that has been damaged by the unreliable supply. So I think, yeah, easy man. If we focus in the unreliable electricity supply, which is probably the most interesting part, we see that, for example, we see here a sample of data that was collected actually by eHealth Africa. And there would be two main variables. One is like, is there actually grid infrastructure in the location where the health facility is located? Well, is, and also what is the state of that grid infrastructure and the supply that it can provide. So while we do see that around 85% of the facilities were in a location where there is existing grid infrastructure, only around 60% of these grids are functioning. So in the end, around the 27% of the total surveyed had non-functional grid infrastructure, which, I mean, it might be easier to solve than no infrastructure at all, but it's still not ideal, and then the facility cannot operate relying on that. Even from the 291 health centers that were surveyed across 2 states in Nigeria, we see that a very large amount have not received power in either more than a year or actually never. So the fact that these facilities have grid infrastructure becomes almost irrelevant if the power has not been there for years, no? And that is something that we can try to solve and mitigate by using renewable energies. And I think that for is quite case specific what the best solution is. And we see here the range of renewable energy solutions that we could like help to provide or to offer to facilities, and the recommendation would really depend on the situation. We would have like small off-grid systems. This could be for like small health centers far away from the grid, standalone larger systems. Maybe they are off-grid, but they are bigger, or the grid is just not in a good condition. We could connect health centers to a mini grid. They could be connected to the to the grid and have a backup solar battery backup to be able to jump in whenever the grid fails to supply quality electricity. And we could also have solar water pumping, solar thermal for warm water, as was already mentioned before, and also solar for cold storage to like preserve temperature sensitive items like medicines or vaccines. So depending on the solution that we want to go for, the type of appliances to be powered or the ideal type of appliances to be powered would change. So for example, if we're looking at off-grid and standalone systems, DC appliances are normally better, like direct current appliances. They consume lower amounts of power and can offer cost savings, and then they are portable systems. The only problem is that then these systems, if they are standalone, can be a bit more static and more difficult to expand in the future if demand increases. In order to mitigate a bit this risk, we can think of modular components. For example, separate the setup of panels for fridges, which can then be upgraded when a new larger fridge is required. And then on the other hand, if we look at systems that will be supplied through either mini grids or on-grid systems, then alternative current appliances are much better. They're more like it's easier to integrate them in the power supply situation. It's easier to expand the system, and the only problem is that here we face a bit of reduced energy independence. Like it's not about the health center alone, but it's integrated in a bigger solution. And as a mitigation strategy for this, we can prioritize the power supply if agreements are reached with the operators of the either mini-grid or grid, or also even locate powerhouses close to the health center. There's also like advantages to prioritize the power supply for these critical points of consumption. So we see that there are a few variables that really affect what is the best technical solution to improve the reliability of health centers through renewable energies. The ones that we've covered now are, for example, the grid location. How far is it from where we are, or actually is it there? Then the settlement size, like are we talking about a big town? Are we talking about like a small compact community, or actually is it like a very sparse settlement in a rural area? Then the next variable would be like the grid quality. Is the grid working or not? Does it, for how many hours a day does it work? Even if it's working for a few hours a day or for many hours a day, how is the quality of the supply? Like what is the voltage fluctuation and so on? And we find this out through survey. Sorry, the two other variables, we can find them normally out through GIS assessment, so geospatial, using our geospatial tools. And finally, I mean, basically by considering all the different options and the combinations of these three main variables, we would end up either recommending a grid connected system, a grid connected system plus an interconnected mini-grid, an off-grid mini-grid, or more standalone solutions that are also quite relevant for this. So I think now we would present a case study showing how all these variables are like considered to make a final recommendation. And yeah, I would hand over to my colleague Imran, who would walk you through this.
Thanks a lot, Oscar, and thanks for running us through the key main aspects that need to be considered. And I think what you see in front of you is perhaps also one of the key elements to the discussion that we had before, basically, that technology is there, it is proven, there is no issue with that, there is a willingness to implement it. I think as other participants said, that how can we scale it up and how can we basically tackle it from a program level point of view. And this is really what integration has been doing in Nigeria with our partners at GIZ, at REA and World Bank as well, to kind of take a geospatial approach and to really see, okay, where are these centers, which of these are the ones with higher priority? And here is one approach that we look at, in terms of their supply and in terms of the grid infrastructure. And on these lines, we have a case study to also share with you. So together with eHealth Africa, basically under the GIZ program, Nigerian Energy Support Program, there was an activity which is still ongoing to select some key healthcare points along key junctions of the grid. I mean, the idea was also to use the information from these healthcare centers to basically assess the quality of grid supply. In addition to those measurements, there were also remote surveys that were undertaken. And based on this information, this GIS-based information and then primary data that was collected, a model was developed basically to create an understanding of the grid quality and the supply. So what you can see here is kind of which are the areas that are connected and have good supply, which are the areas that are connected but do not have good supply. And out of that, basically, one could design electrification options, as Oscar was just mentioned before as well. If the area is really good, should we go for a grid connected option or not grid connected option? So basically what we did in this study was, it was conducted in Kano State, and around 1,400 health points were collected. As you can see on the screen, it's quite dense. I think that's also an observation to be made that, there are a lot of these small healthcare centers that Oscar talked about, not requiring a lot, but still being in close proximity. So the numbers also do matter. However, when we overlay this information with energy supply data, which is coming from other sources, and REA is also a big part and has many programs in this direction as well, we can basically start to look at, okay, what are the areas that are receiving better power, and where are the areas where we need to look at off-grid solutions more. So based on this analysis, we now overlay it with information available about grid. So what you see on the left is basically the grid lines with a buffer of around 3 kilometers. That's the orange one. And then from such geospatial analysis, now you can do it at scale. So it's not about just 50 or 100. You can basically do it for thousands of them. And then what we are able to do is basically able to see, okay, how many of them are within a respectable distance to the existing grid. So in this case, we can see that about 80% of them are within 3 kilometers of the grid. The remaining 15% are 3 to 15 kilometers. And these are the ones that you would normally expect to be connected in future years. So not in immediate years, but later. And then there are also those which are really far off, completely off grid, like more than 10 kilometers away from the grid. And this first allows you to build a real geospatial picture. Okay, how are these health centers located? And then based on that, one can look at different options in terms of when we collect more information about the quality of supply. So if the quality is good in those areas, that means you're talking about at least 8 to 10 hours of reliable grid supply, because as we had our colleagues from eHealth Africa also presenting, that just because power is available doesn't mean it is usable. It needs to be of a sufficient quality with less voltage fluctuations to actually be able to operate these sensitive equipment as well. In those cases, where we can then collect information, these are viable, they have grid supply, we could go with grid connected options. Otherwise, we could look at interconnected mini grid options. That means that the systems are usually able to operate independently of the grid when the grid supply is not there or not reliable. Another layer on that is basically that when you are looking at off-grid systems where you are saying, okay, probably electric supply is not available there, then you want to look at off-grid options, and there a decision could be made whether this system could be part of a mini grid or should it be a standalone system on its own. So for example, then the information and the collection of information and value of entities like RIA becomes really valuable, because then you can see they have a program on mini grids, the NEP program, which says, okay, where are the upcoming mini grids? Then there is a program about health facilities. And if you overlay both of them, then you can say, aha, we need so many healthcare facilities here, or these are the ones that we need to electrify, but here is the upcoming mini grid next to it as well. So we rather synergize it together and connect it to that mini grid basically. And for those that do not have any upcoming mini grids in the pipeline, then really then you can go with very targeted standalone systems as well. So this kind of an approach really allows you to break down the big problem into solvable chunks and customized solutions, basically. To go a bit into detail, for example, here you can see that, these systems that are really far away from the grid, you have these more than 10 kilometers away. So here you can see an example, just from remote assessment, you can see, okay, this is really in a dense settlement, and you would rather go for an off-grid mini-grid solution here instead of this one, which is far away and could be like a more standalone system as well. And these kinds of data sets, what we were talking about earlier as well, availability of this actionable information. Because, the cause is there, everybody understands it, but we need tangible data sources and actionable data sets to be able to make decisions on it and support the sector, basically, not only public sector, but also private sectors. To be able to identify these locations and then find solutions for those. In terms of areas which are closer to the grid, like we said, that this is within the community, you are looking at areas which are considerably within the area, but then here you need to do perhaps further measurements on grid quality or grid supply as well. And in this context, we are working in Nigeria, for example, with different agencies to also collect grid supply data, where we are installing energy meters or energy measurement equipment on transformer level to really understand, okay, what is the power supply, how is that affected, how many hours of grid supply is reliable, what are the fluctuations, and then really be able to say, okay, does it make sense here? Can we connect to the grid or can we not connect to the grid? So what we found in this study, for example, that a lot of settlements that are connected to the grid have not really received power for several years on end. And that is then really a decision point to say, okay, there is grid there, but if we just rely on it, then, we are not really addressing our problem here. So therefore, we need to go for either an interconnected mini grid solution, whereby you can operate even when the grid is not there, or for communities that are really small, or whether you need for critical services. Perhaps you must need to make a decision that, we found out there is grid, but it is unfortunately not reliable. And for this critical service in this area or in this state, we must provide it a standalone solution of its own. So those kinds of decisions can be supported with such analysis. So having looked at it, I mean, I hope we were able to present the approach, how geospatial mapping of data and basically accumulation of data from different sources can really help to trigger this program level approach to solving this issue, for which we are all here. And I would just like to wrap up with some key considerations that we have in this area. So why are RE solutions needed? I mean, we basically have talked about it, right? The energy security can be promoted for provision of life-saving facilities. Another important point is also that with respect to COVID-19 response mechanisms, all the agencies and Nigeria as a whole needs to react fast, right? It's not a matter of years, or it's rather a matter of months or weeks to be able to deploy vaccinations when they are available. And for this thing, as other presenter has also showed that, we need to have fridges that can store these vaccines. Otherwise, that's a lot of going to be wasted. But to build this infrastructure, you are going to need to react on a really fast pace. And traditional electricity supply sources are going to shortfall. At the same time, Nigeria is in a unique position. It has a very good renewable energy market, solar home system market is even much more progressed on mini grid sector compared to other countries. And therefore, it can leverage on those renewable energy solutions to say, we have those solutions available in the market. Can we not quickly identify which healthcare sector needs which solution, and then we really make it available quickly? Of course, another consideration is also to reduce CO2 emissions, right? And especially when we talked about such large facilities which requiring large volumes of fuel every day to operate, you are going to reduce CO2 emissions, and not only just emissions, but you are actually reducing them where it matters the most as well, at those facilities where those people need to have the better environment to recover as well. Another point then we want to look at is basically how can we now speed up deployment of such effective RE systems? So as we established that, it's not just you need a system, you need to really make sure which kind of system you need. And for that, what we really suggest is that, on a program level, there should be synergies sought between electrification activities and then initiatives that target on development of health facilities. So co-location initiatives, studies or programs that find, okay, we want to find out where could be mini grids that have health facilities next to that. We want to find out where are health facilities so that we can incentivize those areas for development of other renewable energy solutions. Those factors should now also come into consideration when developing pipelines for these renewable energy projects. At the same time, we should also be thinking about not only the existing facilities, we should rather be talking about how are we going to basically enhance the network of these facilities. So at the moment, there are centers that have been located, which are being studied, that we are looking at, and we want to supply them with renewable options. But perhaps a more important question is that overall in the network, where are the missing areas? Where do we need future centers? Where do we need future supplies? And those things should be considered as well to make sure that, the future looks much more secure and we are able to leverage on these technologies in a much more efficient manner. At the same time, as we also look to there that, there should be a market development for more RE-compatible medical equipment. So a lot of companies are already producing DC appliances like fridges and other measurement devices or diagnostic devices. They should be made available. Promotion of those in local markets and availability of after-sales services is also a key factor so that they could be scaled up. And as we said that, using GIS-based approach to learn grid supply and quality assessment can then basically help to identify which equation have a higher priority and what are the solutions that are most suitable for those locations. I mean, once we do all of that, the work is not done. The last part is really, as Dr. Osman also said, we need a sustainability framework, basically. How do we make sure that this stays and it's not just like a one-time intervention, as my colleague from Heaven Hill also nicely said, To get a sustainable solution, what we need to ensure is that these communities who are the recipients of these facilities are also on board. They need to be made aware that these facilities are for them. This will help reduce vandalism. This will help reduce misuse of these facilities. At the same time, we need to understand the local context as well and provide solutions that meet those requirements. There could be communities, for example, who have a health center and a direct community center next to it, or another facility next to it, and just coupling them and providing them a combined energy solution might be in the best interest of that community to get them on board. Or as there was a question whether there are systems that have excess electricity to sell to these communities. Perhaps those aspects should also be explored, that you need to have a certain surplus to be able to sell it and then also generate some revenues for maintenance for that system. And to be able to do all of that, really what you need to do is to also monitor energy consumption of these facilities that are going to be installed or have been installed, and also use it proactively for future planning. I think one big mistake that is happening in the sector is that there's a lot of collection of data, but it's not being channeled or filtered through to those policy decision makers to say, okay, what does this data tell us? And I think here I must also applaud the initiatives like eHealth Africa is undertaking. This Meta Fridge study that we just learned today. This is tangible data that can help us move forward. We learned about, okay, we have issues with our voltage supply. We learned, okay, basically only 30% of power that is reaching these communities is usable. Else it's not usable. And those kinds of things need to be made visible. In terms of really operating them, adequate measures for infrastructure and for O&M needs to be ensured. What we mean by that is that, it's not enough to just install these systems and then nobody is there to take care of them. We need proper infrastructure and proper facilities to make sure that, there is regular maintenance. And here again, Nigeria is in a unique position. The private sector is in such a good position and is already very active in providing renewable systems, whether it be off-grid solar home systems or mini grids or embedded systems. And the country can really leverage on that to make sure that, the ones that are near to them should be tapped into providing facilities here. So whenever a healthcare center is being deployed, a system is being deployed, perhaps one could say, okay, you need to identify the closest service provider as well who is going to operate that as well. That will automatically force the supplier or the EPC contractor or the energy sales supplier to say, okay, I know that there's 10 kilometers away, there is a mini grid and this company is operating them and I will just tie up with them that they will provide these services. So find those regional solutions. Another aspect that we need to look at is that, once the market is growing beyond a certain initial stage, we really need to look at aspects related to reliability standards as well. Because we are now talking about medical devices, as our other colleagues also said. These devices do not operate if the power is not of a sufficient quality. There is a high risk of damage. And then we need to systematically make sure that renewable energy systems that are used to supply to these equipment, energy to these equipment, they need to have reliable standards. And I think this is something that should also be looked at. Furthermore, I think in terms of future investment in the health sector, basically, it should be kept in mind that, whenever we want to have a healthcare system coming up, perhaps one could go in this direction that, renewable energy should be a mandated part of its energy supply to not only reduce dependency on fuel, but also, for all the other factors that we have talked about today. And I think with this, I would just like to come to a conclusion of our presentation. And thank you once again for listening. And we hope that we were able to get a few messages across. And I would now hand back to the moderator. Thank you.
Thank you very much to the representatives of Integration, Oscar and Imran. Thank you so much for your presentation. I personally appreciate the use of case studies to show us what is currently applicable. Thank you for giving us that presentation. And so we can now move on to the time for Q&A. If you are yet to send in your questions, please, you can still do that. Yes, okay, we have one question for Oscar and Imran. It says, what's the meaning of weak grids?
So in terms of, let's say, qualitative assessment of grids, when we are considering grids that are on the periphery of the main network. So for example, usually when you are moving away from larger cities, you are moving into semi-urban areas, and there you have networks. So there is, for example, a medium voltage line going through there. You have probably a low voltage distribution network for that community, but it has received any proper maintenance or repairs in the last several years. And either the power supply is of a very poor quality, or the times of supply are such low that the community basically cannot really depend on that. So weak grid here is basically like a qualification in terms of the condition of the physical assets as well as the supply of electricity. So both those factors go into that.
Okay, thank you very much. I love the use of data to make the presentation and the case. So what challenges does the lack of available data present when developing plans for renewable energy for rural health facilities?
So I think just as we showed that, when you have information, you have certainty about what decisions to take. When there is data not available, then the problem is that when you are looking from a program level point of view, or a program that is going to be launched, for example, under NEP or any other agency, then really you are looking at generic solutions, which basically raise the bar, or let's say make it more difficult to go with targeted solutions. So for example, consider a scenario where you have data available about these healthcare centers, and you know that here are the list which need solar home systems, here is the list which need interconnected mini grids, and here are the systems which need embedded systems. And then when that program is launched, the private sector knows, okay, what kind of investments am I looking at before actually going there? The government sector knows what kind of capital needs to be raised for that. As opposed to that, when you have a blank list with all the names in it, and basically you are basically playing in the dark in that sense. And then there is high risk of undersizing and oversizing. So I think we should not stop our effort if data is not available, but it also shows you that the accuracy of the interventions and the impact can be much higher as more data is available.
Okay, thank you, Imran. Do we have any other questions for the integration team? Michael, I don't know who your question is addressed to, but it says, is NCC playing any role in accessibility of healthcare services for equal access to healthcare?
Can you repeat the question? Sorry, I didn't hear it.
I'm not so sure the question is for integration, but
okay.
Yeah, I'm reading. I think it was for previous presenters. Please, if you have any other questions, please send them in.
Please, can you repeat the previous question if I can attempt to respond to it? Okay, NCC and what?
Yes, okay. It says, is NCC playing any role in accessibility of healthcare services for equal access to healthcare?
Okay. Actually, I think NCC is doing. I remember there is this U-Reporters. I don't know whether you've heard of U-Reporters. So yes. U-Reporters actually do conduct some surveys and share some information. So, and I believe that can actually be linked to increasing access and public enlightenment. I hope you understand. I hope you know that access to health information is also very critical in disease prevention and health promotion. So actually, I believe NCC is doing, but what we are to consider is coverage. Despite this availability of internet access, so I think other can be very instrumental in increasing equity in access to healthcare among Nigerians and generally in developing countries.
Thank you, Dr. Usman. So we have another question for the integration team. It says your data collection is quite impressive. What are your recommendations about collecting data at either regional or national level?
Oscar, would you like to take a go at it?
Yeah, sorry, but I did not.
The question to someone or to all the panel.
Recommendations for data collection, I think.
Oh, yeah. I mean, of course, having a team of enumerators and having the time and resources to do it is the first step. But then there are other tools that one can use to aid. We normally use open source tools that are made for this purpose. For example, Kobo Toolbox is the one we normally use and is quite helpful. It's open source. It is designed for this either like humanitarian or development approaches, and it is very easy to export the data into Excel and to analyze it later and on the go. And it can be deployed from any smartphone, for example. So yeah, and then of course to reassess the surveys as we go, because normally you can one can design a survey, and then once analyzing the data, it's easier to detect like maybe the flaws of how the information was collected or asked for. So just keep it a bit dynamic, and yeah. I don't know if you want to compliment Imran, but that would be my answer.
No, I think that's probably been our experience. So integration has been conducting surveys with our local partners since 2014 in Nigeria. And I must say we have revised our forms multiple times. And it's actually like when the national colleagues are on site, that's when you really get to see, okay, what you can collect and what you cannot. I think one thing that we have done, Oscar, you have been part of it as well, that when our team is on site, we make sure that we are connected with them via WhatsApp or whatever platform to also be able to dynamically react to on-ground situations. Because, you know, when people who are going to these remote communities often do not have the exact context because they have not been trained in that. They are on a situation and say, okay, I see a big transformer next to me, or I see a big generator here, but the person who is supposed to help me is not there. And then you can quickly say, okay, but can you just make a picture of the nameplate ready, you know? And that's good enough information for you. So to be able to have a dynamic mechanism where you're able to react to these kinds of situations often is really critical to making sure that you are collecting valuable information on site.
Yeah,
Thanks.
Exactly. I think that the live support and being able to have a team remotely offering support to the team on site is really crucial. Like as an anecdote, it's happened to us that we were trying to survey a facility, and the coordinate maybe that was provided to us took the technical team on ground to like middle of the bush, and then yeah, you need to reassess on the go. So it's quite helpful to be able to have two teams. Like of course the one on site is the most important one, but also some remote support.
Okay, thank you very much, Imran and Oscar. We do appreciate you coming to give us this presentation today. Thank you very much. And with that final presentation, we've come to the end of this event. We've discussed the challenges, solutions, partnerships, and different organizations have given us practical examples from what they currently do as stakeholders. So on behalf of eHealth Africa and other partners, I would like to thank the panelists, the speakers, Onche, Ugole, Tahi, Buhari, Dr. Ifunaya, Ilodibe, Stanley Umunuma, Oluwatobi Shoyombo, Dr. Usman, Mohammed Ibrahim, Mohammed Imran, and Oscar Monet for being here with us today. Today's roundtable discussion has been very engaging. Really, we got the chance to appreciate the power, supply, and quality challenges that are almost universal in most low resource settings across Africa. We also understand the role that public, private, and non-governmental organizations play in increasing renewable energy options for healthcare providers, particularly government-owned healthcare facilities. It's also important that of the role of up-to-date data in formulating policies and planning interventions and solutions for renewable energy in health facility. I'm sure we all have key takeaways from today's discussions. And so the next step for us is that we'll be sending out a survey to get your feedback from today's event. Please, would appreciate if you take 1 or 2 minutes to complete it. The feedback would be used to improve the next roundtable discussions in 2022. We would also send a post-event survey rather to each and every one for all the registered attendees so that you can have access to the presentations. Please, we do appreciate each and every one of you